Welcome, and today we will begin with our breast series of lectures. We will begin with the anatomy of the breast, then benign breast disease, then overview of malignant breast disease, then management of malignant breast disease. So, anatomy of the breast. So, today's lecture will be on the anatomy of the breast. Our outline includes introduction, location, extent, parts, arterial supply, venous drainage, lymphatic drainage, embryology, clinical correlates, and then references. The breasts are phylogenetically considered as modifications of the sweat glands, and are therefore ectodermal in origin. So we should note that the breasts are modifications of the sweat gland and are therefore ectodermal in origin. They are present in all mammals and are particularly prominent in females as the hallmark of pubertal development. The adult female breast is a soft hemispherical structure. It is composed majorly of glandular tissue, a variable amount of fat, and fibrous tissue, and lies in the superficial fascia of the upper anterior thoracic wall. So majorly you have the glandular tissue, fat, and fibrous tissue. So glandular tissue, fatty tissue, and then the fibrous tissue, and then the location is in the superficial fascia of the upper anterior thoracic wall. The fascia invests it, that is, this superficial fascia on which it lies on invests it and forms a radial septa. The suspensory ligament of Cooper, that is, the radial septa that it forms, is called the suspensory ligament of Cooper, which transverse the gland from the underlying fascia to be attached to the overlying skin. So it's pretty easy to understand. The breast is located on the superficial fascia of the anterior thoracic wall, and then this superficial fascia now invests the breast and then forms radial septate, that's radial fibrous tissue known as suspensory ligament of Cooper, and then they transverse the breast to attach to the overlying skin, so from the fascia to the skin, and they divide the gland into 15 to 20 lobes. We'll see this, we'll understand this better as we go on with the lecture. Location. The breast is a bilateral structure located on either side of the anterior thoracic wall. So extent. The female breast extends over the second to sixth ribs from the clavicle to the upper border of the rectus sheath below. That's the clavicle above to the upper border of the rectus sheath below. And then from the midline, just lateral to the sternum, to as far as the mid-axillary line, and it lies majorly on the pectoralis muscle. It also lies partly on the rectus abdominis muscle, and then that's on the rectus sheath, and then on the latissimus dorsi muscle. The parts of the breast: you have the nipple located here, and then you have the areola. The areola is a dark pigmented area just surrounding the nipple, and then just as is established in the introduction, you have the glandular portion, the fatty portion, and then the fibrous tissue. The glandular portion is this area here. These are the glands, which is made up of the alveoli and then the ducts. Then you have the fatty tissue. The fatty tissue is located here. This is all fat, and it gives the breast its contour, its round contour. And then you have the superficial fascia, which is located just above the muscle. It's not shown in this diagram, but the superficial fascia is located just above the muscle. And then beneath the superficial fascia, you have the retromammary space, and then you have the muscle here. Now the structure of the breast. The breast is made up of 15 to 20 lobes of glandular tissue embedded in fat. The fat accounts for its smooth contour and most of its bulk. So majorly, the breast is just like glands within fat. So glands in fat is the breast. The glands are responsible for production of milk, while the fat is responsible for the contour of the breast and accounts for most of the bulk of the breast. The structural unit of the breast is the glandular tissue, that is the acinus. So here is an acinus here. So this round structure here is an acinus. Groups of acinus form a lobule as shown in this diagram here. So this is a lobule. This is one acinus here, this is under acinus, and this is under acinus. So groups of acinus form a lobule, while groups of lobule form a lobe, just as seen here. This is a lobe that is formed by group of lobules. Now these lobules are separated by fibrous septa running from the subcutaneous tissue to the fascia of the chest wall. Now these fibrous septa are called ligaments of Cooper. Remember, as we earlier established in the introduction, we said you have the superficial fascia just here, shown here, just above the muscle here, and then we said you have the subcutaneous tissue just beneath the skin here. So from this fascia now to this subcutaneous tissue, we have fibrous septa that run across. See them here. They are this whitish structure here. They run from this end to this end. Now as they run through, they separate these lobules and lobes. Now by separating it, it now divides it into about 15 to 20 lobes. I think that's easy to understand. So a suspensory ligament of Cooper runs from this superficial fascia to the subcutaneous layer here. We would see the clinical importance of this suspensory ligament later on in this lecture. Each lobule drains by its lactiferous duct onto the nipple, which is surrounded by the pigmented areola. So each lobule drains by lactiferous duct to the nipple here. So these are the lactiferous duct, and here we have the lactiferous sinus, which is an enlargement of the lactiferous duct. So these are lactiferous ducts that drain each of these lobes, because the lobular ducts are the ones that drain the lobules, and then lobular ducts drain into the lactiferous ducts that drains the lobe eventually onto the nipple. And then around the nipple we have the pigmented area, which is the areola, and then this area is lubricated by areolar glands of Montgomery, and these are large modified sebaceous glands. Remember, the breast is a modified sweat gland, and the glands of Montgomery, which are found on the areola, are modified sebaceous gland. The male breast is rudimentary, comprising of small ducts without alveoli and supported by fibrous tissue and fat. Insignificant it may be, it's still prone to major diseases that affect the female organ. Arterial supply. The axillary artery, via its lateral thoracic and acromothoracic branches, supply the breast. And then we have from the internal thoracic artery, that is the branch of internal thoracic artery, that's the internal mammary artery, which gives off perforating branches. And these perforating branches, they pierce the first to the fourth intercostal spaces, then transverse the pectoralis major to reach the breast along its medial edge. The first and second perforators are the largest of these branches. So the internal mammary artery, which is a branch of the internal thoracic artery, gives perforating branches to the breast. And then you have the intercostal arteries via their large perforating branches, which is a relatively unimportant source. So majorly we have the axillary artery and the internal mammary artery. So the axillary artery is comes from the lateral edge, while the internal mammary artery comes from the medial edge. Venous drainage. It is fairly complementary with the arterial supply, but distinct in detail. So majorly the veins follow the arteries. Remember, we said for the medial side is the internal mammary artery that supplies the breast, and then from the lateral side is the axillary artery. So as you can see here on the medial network, you have perforated branch of the internal mammary vein draining the breast. On the lateral aspect, you have the axillary vein draining the breast, and then on the posterior aspect, it is drained through intercostal veins to join plexus of vertebral veins and tributaries of the azygos vein. Now this plexus of vertebral veins is very important. They are valveless, and we'll see its clinical importance when we discuss malignant disease of the breast. Lymphatic drainage. Lymph drains from the gland along vascular tributaries via two lymphatic plexuses, the subcutaneous subareolar plexus of Sappi and then the submammary plexus on the pectoralis major. So it's more like you have the subcutaneous that's a superficial drainage, which is the subcutaneous subareolar plexus of Sappi, which is superficial lymphatic drainage, and then you have a deep lymphatic drainage, which is the submammary plexus located on the pectoralis major. Although there's a communication between these two lymphatics from the two plexuses, they mainly drain laterally to the axillary nodes. About 90% of lymph drains laterally to the axillary lymph nodes, and then superiorly to infraclavicular and lower deep cervical lymph nodes, inferiorly to lymphatics on the anterior abdominal wall, medially to nodes around the internal thoracic artery, and then a small part of lymph drains to the opposite breast and axilla. So this diagram here shows the lymphatic drainage. So we say laterally drains to the axillary group of lymph nodes here. So about 90% of lymph drains into the axillary group of lymph node, which is made up of the apical lymph node, the anterior axillary lymph node, the medial group, the posterior group, and then the lateral group. I would say superiorly drains to the infraclavicular lymph nodes, and then the lower deep cervical lymph nodes, and then laterally drains to the lymph nodes, the internal thoracic lymph nodes that surround the internal thoracic vessels laterally, and then inferiorly into the nodes draining the anterior abdominal wall. So in embryology, the breast develop as an invagination of the chest wall ectoderm, which form a series of branchy ducts. So an invagination of the chest wall ectoderm, and then subsequently forming a series of branching ducts. Shortly before birth, this invagination everts to form the nipple. So an eversion of this invagination forms the nipple. At puberty, alveoli sprouts from the ducts and considerable fatty infiltration of the breast tissue takes place. So the fatty infiltration of breast tissue takes place at puberty. So clinical correlates. Abscess drainage should be by radial incision to avoid damage to the duct system. Because of the arrangement of the ducts, so as not to injure it, a radial incision following the contour of the breast is done to drain an abscess. Now, a breast cancer that has spread by infiltration may invade and become attached to the fascia and the pectoralis major muscle beneath it. So there could be infiltration of the fascia and pectoralis major muscle by the cancer, and it will cause attachment or fixation of the breast cancer to the underlying chest wall. Now, if the suspensory ligaments are invaded, remember that the suspensory ligaments, they connect the fascia of the anterior chest wall to the subcutaneous tissue underlying the skin of the breast. There's a connection. So if they are invaded, they contract and then they produce dimpling of the skin seen in breast cancer. Now, if the lactiferous ducts are affected, the lactiferous ducts of the breast, if they are affected by cancer, it produces nipple retraction. So infiltration of the lactiferous duct by cancer cells causes nipple retraction. Okay, so I hope you understand that. Then if the spread has involved and blocked the lymphatics of the breast, that's the subdermal lymphatics of the breast, skin edema will occur and it will result in peau d'orange. Then cancerous infiltration of the axillary lymph nodes may produce arm swelling known as lymphedema. So here are some diagrams shown here. So the first diagram shown is peau d'orange. As you can see, the picture looks like the back of an orange peel, thus the name peau d'orange. And as we said earlier, it's caused by infiltration of the subdermal lymphatics by the malignant cell. So when it blocks the subdermal lymphatic, there is subdermal edema, and it appears as peau d'orange. The next diagram is nipple retraction. Remember we said nipple retraction occurs from infiltration of the lactiferous duct by malignant cells. It causes nipple retraction. Then the next diagram shown here is lymphedema, when the axillary lymph nodes are blocked by invaded by malignant cells. They are blocked and then they cause lymphedema. Remember that the axillary lymph nodes, they drain more than 90% of lymph from the breast. Now, quick question. Intradermal swelling and pitting of the skin may be seen in breast cancers. What is the anatomical explanation for this? I'm pretty sure you can remember because the answer is already here. It's due to skin edema and is known as pudorunge. It's a classical sign of advanced breast cancer and it's caused by blockage of lymphatic drainage of the skin by cancer cells. So the cancer cells block that lymphatic drainage of the skin and then it leads to that dimpling of the skin and it is seen as pudorunge. So references, we have Bailey's and Love, Essential Clinical Anatomy, Harold Ellis Clinical Anatomy, Bedo Textbook of Surgery. Thank you, and I hope you enjoyed this lecture and you picked one and more things from this lecture. So I look forward to seeing you in our next lecture, which will be on benign breast disease. Thank you once again.